Hi, welcome to Podiatry Practice Mastery. Don here. I think I'm back on my roll again. If you've been following me for a while, I kind of go in spurts. I'm doing the interviews, and now I'm back into doing these little podcasts. We'll see how long it lasts. I think the main reason I've enjoyed it now is now I have a virtual assistant to help me. And she's been putting these. So let me talk to you about the workflow if you want to do your own podcast. This works well for me now. Is I record them on Anchor. That's the one I use. And I label it, give it a name, and then I drop it into the box for my virtual assistant. And she just, when she has time, she uploads them and kind of spreads them out and puts anything else underneath the description. But that's the easiest format now. What I want to talk about today is I wish I had done it sooner, okay? And this is a common comment. I had a patient recently, he had a ulcer on the bottom of his big toe. One of these IPJ ulcers, if you're familiar with those are due to hallux limitus. He had a first ray that was elevated a little bit, and it was jamming of the joint. And he had one on the other side, and he is a diabetic, and he ulcerated, and these things can just take forever, because he was a large gentleman. He worked on big trucks. That was his job. He was a kind of a mechanic or a diesel mechanic, and the darn thing just wouldn't heal. And we had to we're trying to get it to heal, he has orthotics, we tried different wound dressings, but ultimately the whole problem is the pressure and the jamming in the joint, especially at that IPJ joint. And we did it on the other side, and I think we dealt with this ulcer. I think many times I deal with these ulcers for 3 months, 6 months, maybe even a year, because this guy just didn't want to take time off of work. And ultimately, the ulcer just got really big, and we did a Keller arthroplasty. So the only thing I use Kellers for, that's where you take off the base of the proximal phalanx, and to give it better range of motion. Why? Because he's not very active. I know it's a joint destructive procedure, but he's not very active. It'll get him back to work a little bit sooner, and frankly, I'm just not very good at doing Lapidus to bring down the first ray. That would have been another option, but I with this guy, with this IPJ, it's either an IPJ arthroplasty, a Keller, and some people are trying these plantar fascial, partial plantar fascial releases, where you release everything on the medial column. I didn't do that, so I did this. But then afterwards, he said, Doc, I wish you would have told me to do this sooner. I wish I would have done it sooner. And I've heard that for a couple of things. So I've heard that for that. And then I also have patients, they come in and they've tried everything, like cortisone injections, orthotics, and then finally they do shockwave, and they say, I wish I would have done it sooner. So many of these patients I'm finding, they wish it would do it sooner. I want to make a little analogy here between that and how about someone that comes with an infected ingrown toenail. When they come in with the infected ingrown toenail, we do a matrixectomy, or we remove the nail edge. And we numb it up. We say, I know you don't want to do this, but this is what you kind of have to do. And you don't really give them an option. So no one ever leaves without that, because we are so convinced and we are so confident that that's the best thing for them that we do it. And I want to kind of take this now, that same confidence and that same kind of we're defined in the purpose and what they need, and take that over to where I struggle with. I want to kind of explain this, and I think many of us do. Maybe it's just me. If you don't, that's great. But the same thing with doing shockwave and then doing orthotics and doing things like that aren't covered by insurance. And as I was thinking about it, they say many times after they get it that they wish they have done it sooner. And I think that the challenge, it's our belief that they will work for them. Now I've done so much shockwave now that I do believe I know the patients that they'll work for, and my belief system is there that it will work for them. I still struggle, and this is what I've talked to other people about, with orthotics. And the reason I think I struggle with it is, well, will they get better without the orthotics? Or do they actually need the orthotics? Will they be fine just without it as well, right? And I guess you can do that, similar to if they come in with an ingrown toenail, and could you just kind of trim out the edge and trim the callus, or do they really need to do the procedure where you numb up the toe? And in my experience, as I do this longer and longer, I realize, well, it's just a lot easier to just numb it up and take it out than it is to dinker around with pulling down the nail edge with a Band-Aid. That I just don't do that. I know some people, if they don't have the scope of practice, they may do that are listening to this, but I just kind of numb them up and take it out. So it's the same thing for our treatments. What are things that we can be doing, or should we be doing sooner for our patients to get them better, and kind of offering that? And what I found, like my most elegant thing that I've been doing now, I'm always giving it a new name, okay? So what I'm using now is something called a patient treatment tool. And if you want to look at it, I've put it at patientpresentation.com. So if you go to patientpresentation.com, put your email in there, and you can say, like, look at the tool or look at the presentations. This is how I do it now. And so what these are is you'll see there's a list of basically my patient presentations, and they're going to open up, and you can actually use the same ones that I use. So if you have someone with an ingrown toenail, you can use my slides. If you have someone with heel pain, you can use mine. Achilles tendonitis, anything else that you have, you can use it. It's free. Once you open it, put your email. The first time you can get the link to it. It's a link tree. And then I would just save it to your browser so you can get back to it. So you can save it, show it on your computer. You can save it on your phone. You can have your patient open up to it as well on their phone. And it's kind of a cool method of doing it. Most importantly, because then you can show them like the treatment options. And I want to share one way that I preface things with patients. And this is kind of it kind of comes around to, once again, confidence and how you communicate with patients. But I think we're all really bad at it. I shouldn't say everyone. I'm bad at it. I'm trying to work on getting better at communicating better with my patients. In the one transition you're going to find is when I start to treat and explain things to patients, specifically when I do my treatment evaluator. There's a certain slide, if you pull it up on my plantar fasciitis slide. This is the one I use every single day in practice. It's the patient treatment evaluator, or plantar fascial treatment evaluator, and it talks about the different treatment options. And I always say, Mrs. Jones, there are many different types of treatments that you can have for plantar fasciitis. And my objective is to go over them, and I'm going to explain what's the best treatment, in my opinion. And some of these are covered by insurance, and some of them aren't covered. But I'm going to share them all with you. Is that okay? So in that little word right there, where I get permission from the patient, this is something I didn't know, it gets permission them prior to me explaining all the treatments, and then I can explain to them, okay, shockwave is this much, orthotics are this much. I think even though these aren't covered by insurance, they are better treatments, and this is the reason why. And it's a much easier conversation. What I used to do in the past is I didn't preface it, and then when I started to present things, I used to present, like, let's say I talked about cortisone, and I talked about icing, anti-inflammatory, stretching, things like that. And then at the end, I'm almost like apologizing. I'm saying, and then they have their defenses up. Because the first time that you bring up something, just so you know, they're going to say no. They're going to defend, okay? They're going to defend. They're going to say no. Why? Just because that's our natural process. We're going to say no to anything the first time we hear about it. But if I preface it, so as I'm explaining plantar fasciitis, as I'm showing them why it is, and then I go into there and say, okay, Mrs. Jones, I'm going to go over the different treatment options. My obligation to you is to share all the treatments with you. I'm going to share some that are covered by insurance and others that aren't covered by insurance. But the reason I do that is because many times these treatments get you better faster and are going to get you back to whatever your activity is faster. Is that okay? So I would recommend just trying that in your conversation today, trying about getting permission first, and then when you go in to talk about, okay, you need 3 or 6 sessions of shockwave, or you need, or what's essential for you is custom orthotics. That's been working for me lately, and once again, it's doing what works best for the patient. So anyway, that's my thought today. I would love to have you guys try this patient treatment tool. Go to patientpresentations.com, patientpresentation.com, and you can get that tool right there. Try it out. Let me know what you think. Okay, guys, have a good one.